Finals SAQ8 Endoscopic Thoracic Sympathectomy. A. List the indications for endoscopic thoracic sympathectomy (ETS), 25 marks. Indications include hyperhidrosis, for example, palmar, axillary and craniofacial hyperhidrosis, chronic regional pain syndromes, facial blushing, and chronic angina pectoris are manageable by medications or cardiac intervention. B. Outline the general and airway implications of managing a patient for ETS under general anesthesia. General implications. Age group. Patients are predominantly young and fit. However, they may be older with comorbidities, especially if the indication is for refractory angina pectoris. Consider the need for additional assessment and investigation preoperatively. Complications are rare, however can be catastrophic. Ensure the patient has full understanding of the risks versus benefits. Conversion from endoscopic to open sympathectomy is occasionally necessary. Prep and drape ready for thoracotomy. There is risk of major hemorrhage. Ensure large bore IV access is available and 2 group and safe samples for rapid blood issue. Hypoxia is common. Causes includes shunt due to one lung ventilation, atelectasis, and failure to fully inflate the first lung before proceeding with surgery on the second side. Hypotension may occur due to capnothorax. Consider invasive blood pressure monitoring or more frequent non-invasive monitoring. Positioning. Consider complications of positioning. Supine position is usual with reverse Trendelenburg and arms abducted. There is risk of brachial plexus injury. The patient may occasionally be position prone, which has risks such as facial or eye damage, dislodgement of airway, difficulty with ventilation, nerve traction and injury. The patient may also occasionally be positioned lateral with potential difficulty with ventilation, dislodgement of ETT, damage to pressure points such as common peroneal nerve, etc. Airway issues. For bilateral surgery, there is need to achieve collapse of one lung followed by the other. Options include one lung ventilation via double lumen tube or one lung ventilation via ETT with bronchial blocker or ETT with intrathoracic CO2 insufflation or LMA with intrathoracic CO2 insufflation. C. What are the most likely problems to be encountered in the intraoperative and postoperative period? Intraoperative problems. Airway. Malposition of the double lumen tube or bronchial blocker may lead to hypoxia. Respiratory problems. One lung ventilation leads to shunt and hypoxia, and efforts to improve this may actually worsen hypoxia. For example, oxygen insufflation or CPAP to the deflated lung may reduce hypoxic pulmonary vasoconstriction and increases shunt. PEEP to the ventilated lung may increase resistance to blood flow to the ventilated site, increasing West Zone 1 and dead space. For bilateral surgery, atelectasis of the reinflated lung may cause significant hypoxia when operating on the second side. Consider reinflation under direct vision. Cardiovascular issues. Hypotension may occur due to capnothorax. Cardiac arrest may occur due to rapid insufflation. Cardiac arrhythmias may be induced by intrathoracic diatony. Hemorrhage may occur due to inadvertent damage to blood vessels on port insertion and may be catastrophic. Postoperative problems include hypoxia due to atelectasis or residual pneumothorax, lung injury if protective one lung ventilation is not used, and chest pain requiring opioids or other analgesia, and this may necessitate overnight stay.